It's a great pleasure now to introduce Professor Wolfsdorf, who is Professor of Pediatrics at Harvard and also is Director of the Diabetes Program at the Boston Children's Hospital.
So, in the time that we have this morning, I'd like to review with you the advances in management of type 1 diabetes. And as our previous speaker, Dr. Cunningham, mentioned, we recognize that the individuals in this audience come from a variety of countries with various resources. So what I'm going to talk about is, if you like, the idealized view where resources are no limitation and where we stand with the management of diabetes in children. I have no financial relationships to disclose, and my outline is shown here. I'm going to be talking about goals of treatment, the scientific basis of modern management, the methods that we currently use, focusing on blood glucose monitoring, the use of insulin pumps, the use of continuous glucose monitoring that has become available in the last few years, briefly mention what we are able to achieve in terms of outcomes, and some comments about the future. This is a slide that shows my philosophy and the goal of treatment of a child with diabetes today. And that is to enable that young person, boy or girl, to achieve his or her full human potential. This is a picture sent to me from a patient who was at the time about 19 years old. He had type 1 diabetes for 7 years. Diagnosed at age 12 and a half, commenced insulin pump therapy at 5 months of age, maintained hemoglobin A1C, the test that we use to monitor glycemic control, tells us what the average blood sugar has been for the last 8 to 12 weeks. And in this youngster, his entire life, 7 years of therapy, his hemoglobin A1C ranged from 5.5 to 7.4%. with normal being 4 to 6%. And he was an outstanding young scholar athlete and was a champion pole vaulter and graduated high school, went on a scholarship to the University of Southern California as a pole vaulter. And he did this all while living with type 1 diabetes. So this illustrates what is possible with modern management. So, to summarize, the goals of treatment are to achieve normal physical growth and development, to try to maintain normal psychosocial development. The burden of chronic disease in a family, as you all know, can be huge, so we try to optimize family function, try to maintain blood glucose levels as near to normal as possible, avoiding acute complications, which are always present. The threat is always present of either severe hypoglycemia or diabetic ketoacidosis, and then to identify and treat comorbidities, and in particular thyroid disorders, celiac disease, which occur quite frequently in children and adolescents with type 1 diabetes. Now, to understand modern management, one has to pay attention to the most important research study in the modern era relevant to type 1 diabetes. And I'm referring to the Diabetes Control and Complications trial, which examined the effect of intensive treatment of diabetes on the development and progression of long-term complications in insulin-dependent type 1 diabetes mellitus. The outcome of the study was published in September 1993. And the results ended a debate that had gone on for more than 50 years about whether the complications of diabetes, retinopathy, nephropathy, neuropathy, and so on, were caused by the metabolic abnormalities, and in particular, the effect of hyperglycemia. And could this be prevented or ameliorated? And the study clearly showed that hyperglycemia was the factor that contributed to these complications. The main results are shown in this slide. In the upper panel, you see individuals with glycosylated hemoglobin shown on the y-axis here, normal up to 6%. At the start of the study, subjects had values in the mid-8s. Those who were randomized to receive intensive therapy, meaning at least 3 injections of insulin a day, frequent blood glucose monitoring, adjustment of insulin doses, and food intake, were able to lower the hemoglobin A1C to approximately 7%. And you see here the average over the duration of the study, which lasted about 9 years, compared to those who were randomized to receive conventional treatment at the time the study began, which was in 1983. They maintained hemoglobin A1Cs approximately at 9%, so there was a difference of nearly 2% over the course of the duration of the study, as I said, about 9 years. And what this translates to is a significant reduction in the risk of retinopathy progression. Diabetic retinopathy was the main outcome variable in the study, and what this slide shows is the time that individuals were in the study, up to 9 years, and on the y-axis, the rate of retinopathy progression, or the risk of retinopathy progression. And if one takes individuals who were able to maintain hemoglobin A1C close to the target was 6%. So in this group, 7%, 8%, 9%, 10%, 11%, you see considerable increased risk of retinopathy progression over time with higher hemoglobin A1Cs. And this can be illustrated by looking at two individuals, an individual who has had diabetes, who was in the study for 6 years, who's maintained average hemoglobin A1C of 7%. Compare that to an individual in the study for 6 years, whose average hemoglobin was 11%. There's approximately a 20-fold increased risk of retinopathy progression. So, maintaining blood glucose, average blood glucose, measured as hemoglobin A1C, close to the normal range, is the goal of modern diabetes management. So because I practice in the United States of America, I live in Boston, I will sort of have an American or US orientation here, and the American Diabetes Association set targets for plasma glucose levels and hemoglobin A1C for children with type 1 diabetes and stratified them by ages. In the preschool age, say under 6, the target would be an A1C less than 8.5%. In the school age, between 6 and 12, under 8%. In adolescents and young adults, under 7.5%. And if one can achieve less than 7% without excessive hypoglycemia, that would be a very desirable goal. The reason, obviously, for the stratification is that the ability to recognize and independently treat hypoglycemia is more difficult and if in so many cases impossible in this very young age group. The International Society for Pediatric and Adolescent, however, does not stratify and recommends that the target should be less than 7.5% for all age groups. But I think as practitioners, as individuals working with families or with children with diabetes, it's important to recognize that one has to really have individually determined targets and try to achieve the lowest possible hemoglobin A1C that is possible without severe hypoglycemia and frequent mild to moderate hypoglycemia. So, this is about advances in treatment. And advances in treatment are really all about the use of technology. So insulin pumps and meters have been the major technological advances that have drastically altered how patients manage their diabetes today. And one of the most important issues that I'd like you to appreciate is the importance of frequent self-monitoring of blood glucose. Many studies have shown that in the improvement in glycemic outcomes, the improvement in hemoglobin A1C, cannot be achieved safely without frequent blood glucose monitoring. One of the largest studies in terms of the numbers of individuals was a cross-sectional report from the German-Austrian diabetes database, DPV-WIS. This is an observational study in which individuals from 233 centers in Germany and Austria contribute data regularly, and it's been going on for many years. So we're talking here about nearly 27,000 children. And when the statisticians adjust for age and gender and duration of diabetes and the years of treatment and the insulin regimen, insulin dose, body mass index, center differences, the frequency of self-monitoring of blood glucose is significantly associated with lower hemoglobin A1Cs. And the magic number, if you like, is 5 times a day. Now, again, test strips cost money. For some, this is unaffordable. In some parts of the world, the insurance companies or the state health system pays for it. Either way, it's difficult to do, but those patients with diabetes who do this, who check their blood sugars 5 times a day or more, almost always significantly improve their diabetes control. And you see here from their database the sort of relationship. About 90% of those 27,000 children and adolescents were checking blood sugars between 3 to 7 times daily. Small number check very infrequently, small number check even more frequently. But at about 5 times a day, you have a pretty stable improvement in hemoglobin A1C and so on. So blood glucose checking frequently, critically important to improve and to maintain improvement in diabetes control. So the question then that many people ask is, what is the best way to deliver subcutaneous insulin to infants, children, and young people with type 1 diabetes? And these authors, Blair, Peake, and Gregory in the United Kingdom, published this interesting article in the British Medical Journal earlier this year in which they examined this question. And to answer the question, I think it's important to go back to something that I hope you learned in medical school, and that is how the pancreas normally secretes insulin. So what you see here is in the top panel, plasma glucose concentrations varying from approximately 4 millimoles per liter to 8 millimoles per liter, and the arrows indicate breakfast, lunch, and dinner, so 3 meals, and the glucose levels rise sharply, come back down to baseline, rise again, come back to baseline, and so on, and during the night remain fairly stable. The differences here are in adults. Obese adults, slightly higher glucose levels than non-obese adults. And in the lower panel, you see insulin secretion rise and fall in parallel with the rise and fall in glucose, and the middle panel simply shows the C-peptide concentrations. The difference here is that obese individuals achieve normal glycemia, but with higher insulin secretion. So an ideal treatment would be to reproduce this pattern. With each meal, a spike in insulin levels, and then blood glucose would return to normal baseline levels, and the insulin level would return to baseline as well. So a perfect treatment would reproduce. The problem is we don't have a perfect treatment, and we have, in fact, many different combinations and permutations of insulin delivery, going from I would say in some places obviously only once a day, but I think to be honest, the minimum number of insulin injections a day to achieve any kind of control would be 2. S is short-acting, R is rapid-acting, the modern analogs that are available, N stands for NPH. So the minimum would be 2 injections, one before breakfast, one before dinner, of a mix. Intensifying goes to 3 injections. It could be breakfast, lunch, dinner, or breakfast, lunch, bedtime. Again, combinations of NPH, sometimes with glargine or detamere. Increasing intensity with 4 injections a day, or if an individual has snacks in the afternoon and evening, maybe 5 or even 6 injections a day. And then at the bottom here, I've shown CSII refers to continuous subcutaneous insulin infusion or an insulin pump, which is typically a method of delivering rapid-acting insulin analogs. Some people still use regular insulin or short-acting insulin. So depending on the resources available, depending on the willingness of the child and the family, and perhaps the experience of the clinician, one will see various combinations and permutations of these insulin delivery regimens. I'd like to focus our attention on insulin pump therapy. It is my belief, and in our clinic with more than 1,600 patients with type 1 diabetes, we have a majority, more than 50%, at least 800 or 900 patients using insulin pumps. They were introduced in the late 1970s, and then with the Diabetes Control and Complications trial showing the importance of intensive therapy and lower hemoglobin A1C, there became renewed interest. There was renewed interest in pump therapy, and this method of delivering insulin has evolved and is now widespread. Now, how effective is it? Well, many of the issues in diabetes relate to not just the technology, but how well the tool is used. And the hemoglobin A1Cs, on average, are reduced about 0.4 to 0.6% compared to multiple daily injections. So a small advantage over multiple daily injections. In some studies, as little as 0.2%, in others, more than 1%. Also, not only does the hemoglobin A1C or the average blood sugar improve, but the frequency of severe hypoglycemia can be decreased with the use of pumps. And weight gain, which was an early concern with pump therapy, we now know can be prevented with appropriate dietary counseling. So I was able to get a copy of this slide from one of the pump manufacturers in the United States, just to illustrate that in 1990, the use of pumps in the United States in patients with type 1 and perhaps a small number with type 2 diabetes has gone from 6,600 to, in the year 2008, about 400,000. So this enormous increase in the use of pumps for the treatment of diabetes in children and adolescents and adults, and as I said, even some patients with type 2 diabetes, but predominantly type 1 diabetes. And although this slide is for data it shows data in the United States, it's also true in many parts of the world that pump usage has increased dramatically. So how does an insulin pump work? You see here the pump, the infusion set, and so on. It's really a pump is an electronic insulin syringe in its simplest form. It's a small computerized device, it's battery operated, and it allows the user, the patient, to control exactly how much insulin is delivered. So there's a pump reservoir that looks like a syringe in which an individual puts 2 or 3 days worth of insulin, perhaps 200 or 300 units or less, depending on how much is used. And then there's a thin plastic tube called the infusion set, which you see here, that ends in a very fine cannula that is inserted under the skin and lives in the subcutaneous tissue. Could be on the anterior abdomen, could be on the buttock, could be on the back of the arm or on the thigh. And insulin passes from the pump reservoir, from this device, through the tubing into the subcutaneous tissue. Now, shown in a little more detail is that the infusion set, this thin plastic cannula with a thin plastic tube with a tiny cannula, barely visible here, that actually inserts under the skin. And this is still a big technical problem. Pumps work extremely well for the most part. The technology has advanced tremendously. This still is the weak link because this sometimes becomes occluded, sometimes kinks, sometimes slips out, and of course, when that occurs, patient doesn't receive insulin. So, with modern flexible insulin delivery regimens, whether it's with a pump, whether it's with multiple daily injections, abbreviated MDI, these have the potential, and I underline the word potential, to more closely simulate physiologic insulin secretion. Because how well patients do very much depends on their understanding of diabetes management and their motivation to do the things that are necessary to achieve excellent control. I've already highlighted the importance of frequent self-monitoring of blood glucose. And the second extremely important issue is to remember to give an insulin bolus before eating a meal or a snack. And these are the two major limitations in affecting outcomes for children, many children and adolescents with type 1 diabetes. So part of the discussion that I as a clinician or that you would have with patients is understanding the requirements for success and the risks and benefits. And my own approach is I do not force anyone to do anything. I encourage patients to choose the regimen that they believe they will most be able to adhere to. And many of our patients move back and forth. They use injections for a period of time, then go on pump. Most patients, once they start on a pump, remain on a pump for the rest of their time. So the advantages of pump therapy. I think there's no doubt that pumps or continuous subcutaneous insulin infusion is the most physiological method available to deliver insulin. It's not a physiologic method. It's the most physiologic. To deliver insulin physiologically, you have to put it into the portal vein, not under the skin. We are not there yet. Rapid-acting insulin analogs can mimic the endogenous peak and the short duration of insulin after a meal. There's reduced variability in the absorption of insulin from the subcutaneous site. You can vary the basal rate for different conditions. These modern so-called smart pumps can be programmed to have correction factors to treat high glucose levels. They can be programmed to have insulin carbohydrate ratio, so the patient simply has to say, I'm going to eat 50 grams of carbohydrate, and the pump calculates how much insulin would be necessary. We can make very, very tiny dose adjustments, as low as 0.025 units, whereas with a syringe, you cannot really accurately measure insulin below a half a unit. It also has a feature called insulin on board. The pump knows how much insulin you injected earlier and how long that effect will persist to try to prevent what's called stacking. Patients see their blood sugar is high, so they want to give repeated doses of insulin to bring it down quickly. The pump prevents that from happening. And the modern pumps allow the glucose meter to communicate directly with the pump so that the information, as soon as the patient has checked the fingerstick blood glucose level, the information is in the pump and the calculation for the insulin dose is done for the patient. Other advantages is that they have electronic memory that can be downloaded, so you or I in the clinic can evaluate the patient's compliance. And the most important question, especially with adolescents, that I need to know is, are they using the bolus calculator, and are they actually giving boluses of insulin when they eat? The importance of this has been very clearly shown, that a patient who misses 2 boluses, meal boluses a week, in other words, in a sense, is not given insulin before a meal twice in a week, the hemoglobin A1C rises 0.5%. This is one of the most important reasons that adolescents don't achieve optimal goals, because they forget to give themselves insulin. Also, the pumps have mealtime alarms that vibrate or give a sound remind the patient to check the blood glucose, and they remind them to change the infusion set after 2 or 3 days. So with pumps, patients can have a more normal lifestyle. They can eat their meals and snacks, work, exercise, sleep based on a personal schedule, and not based on the peak action of an insulin that was given many hours earlier. And so I think the data are very clear that when one compares pump therapy with multiple daily injections, quality of life is improved and there's higher treatment satisfaction. And it was interesting that in the year 2000, a survey was done of healthcare providers who themselves have type 1 diabetes. This was members of the American Diabetes Association and the American Association of Diabetes Educators. More than 60% in the year 2000 were using pumps. So these are expert healthcare providers who themselves have diabetes. As I said, not all, but a majority were using pumps. There are risks associated with pump therapy. There's no depot of long-acting insulin, and so if there's a failure of insulin delivery, there is an increased risk of diabetic ketoacidosis, and training and education about this is extremely important for anybody using a pump. The importance when the blood glucose level is high to measure ketones, which is an indicator that there is a failure of insulin delivery. So, to be successful with insulin pump therapy, patients must understand the pump is not a cure. Real effort is required to benefit from pump therapy. They have to check blood glucose levels at least 4 times a day, and as I said earlier, 5 times a day would be even better. They have to be committed to achieving the goals of intensive therapy. They've got to be willing to record their data. They've got to be willing to follow up regularly, at least every 3 months in our sector. They have to have a good understanding of diabetes management, and especially the role of nutrition and carbohydrate counting. And as in most things, the best predictor of future success is past success. So patients who are terribly poorly controlled tend not to do well with pumps. So at least starting with fair control, an A1C of under 8% or under 8.5% is usually a good place to start. So what have we achieved in the United States? In a big study, again, these are observational, cross-sectional, not longitudinal study. Nearly 3,000 youth in the United States, 22% were using pumps and had average hemoglobin A1C of 8%. 25% using multiple daily injections with glargine and rapid-acting insulin analog, about 8.5%, and so on and so forth. So pump therapy tended to be used more frequently in older youth, in non-Hispanic whites, in females, and in children living in families with higher income and education. And in all the age groups, children, adolescents, and so on, pump use was associated with the lowest hemoglobin A1C. Regardless of the regimen, and this is important to appreciate, hemoglobin A1C was more than 7.5% in more than 70% of adolescents. So the authors wrote...
You've got 1 minute.
1 minute?
Yep.
Okay. The high percentage of youth with hemoglobin A1C levels above the target value and with poor glycemic control indicates an urgent need for effective treatment strategies to improve metabolic status in youth with diabetes. So, despite the technology available, we're still not achieving good enough results. The next major advance has to do with continuous glucose monitoring, and what this involves basically is a sensor that is under the skin that transmits a signal that gives an average that gives a continuous readout. So this is what one sees with intermittent glucose measurements, and with a continuous glucose monitor, you see a more complete picture. And this is a sort of an output of continuous glucose monitoring. This shows an individual whose glucose levels are low during sleep, high after breakfast, and yet hemoglobin A1C is 6.7%. So when you see data like this, it gives you an opportunity to counsel the patient to reduce insulin overnight, to manage breakfast differently. And now we are able to link these two devices, and this is called sensor-augmented pump therapy, which is now the sort of cutting edge of technology to use both continuous monitoring and pumps. And in the very near future, we're going to be seeing so-called closed-loop insulin delivery or artificial pancreas, where the sensor communicates with the controller has algorithms that inform the pump, and that would be the method of insulin delivery. Thank you for your attention.